Apologies, Anu.
Yes, Melaine Coward, Matt Stevenson, Dami Adedio, and Jane Dale.
Okay, but we have Fran in lieu of Dami, so
Okay.
Dami being on maternity leave, probably she's officially away, isn't she? So
Of course, yes.
Okay, thank you. Any declarations of interest, please, on anything that is on the agenda? Just to say the non-executives obviously do have an interest, as in the closed agenda, but they won't be in for that particular item. Right, okay, we'll move on then to the minutes of the meeting dated the 1st of September. That's the open minutes. There are 11 pages. I won't go through them page by page, but I'll ask if anybody has any comments or corrections. I'm not seeing any. So we're happy that those are a true record of the meeting. Governors, please say yes.
Yes.
Or stick your thumbs up, something. Thank you. Right, let me just move through them. And then we'll do the actions arising on these minutes first. The first action, which is open, was consider public area. Tom was on Tom to consider public areas such as libraries for virtual consultations. I think Tom on. Not sure he is yet.
Yeah, I'm on.
Oh, Tom, yeah.
We did consider that, but we've gone virtual for everything now for obvious reasons.
So we're using virtual for virtual consultations at the moment.
That's right.
Yeah, yeah, and you know that's going to continue for the foreseeable over winter, I'm sure.
Yeah.
Okay. The next one, the assurance report was sent with the draft minutes. Collaborative refresh, that was basically open to anybody to let us know if, particularly let Anu, Tom know if there's anybody that we should be targeting for feedback. And we haven't had anything so far on that, Anu.
Apologies, no.
Okay. But we're carrying on with the refresh anyway, aren't we, Tom?
Yes, yeah, we've got it on the agenda today, Andy.
Yeah, it's later on. Okay, we'll deal with that then. The newsletter was shared with governors on 2nd of September. Thank you, Anu. The next was on the EDI and wellbeing update, and Louise has the NHS improvement are busy cancelling the meeting, so we haven't taken that any further yet. So we will defer that till the next meeting. That's fine. Okay. So then we moved on to the special meeting. That was the meeting on the 21st of October, was to receive the annual report on accounts. It was a single item meeting. Anybody got any comments on the accurateness of those minutes, please? No. So we'll take those as a true record then. Yes, good, okay. Now, before we go on to the next thing, I know it's on the agenda later, but I wanted to take this opportunity to welcome the new governors to the Council of Governors. So we've had successful elections in all but one constituency. So welcome Francis Ansell for Elmbridge. Welcome Emma Gilmore for Spelthorne. Welcome Sue Bell, Sylvia White and Lily on re-election to Runnymede, Surrey Heath, Windsor and Maidenhead. On the staff side, welcome Andy Brown for the volunteers. Very welcome. staff again, clerical, managerial, Aidan Parsons, welcome. And on medical and dental, Mohammed Imam, welcome. So good to see such a good turnout and that we've got some new governors on board. Bear with us, this first Council of Governors meeting might be a bit difficult. Too many three-letter acronyms. Do put your hand up if you don't understand something, that's fine. It will become clearer in at least 6 years. So it does take a while sometimes on the NHS side. And again, although we'll cover it later, I do want to formally record our thanks to Danny Sparks, Chris Marks, Julian Roos, Oscar Garcia Casas, and the fat Neil Adolphus, who stood down as well. So thanks to all of those. Okay, so we're going to move on now to the feedback from the governors and governor activities. As we have no lead governor at the moment, Michael, I'm going to guess that you're going to lead on this, are you?
I'm happy to just ask the council to accept the report as published. Anu has done a wonderful job in doing that. It was compiled by her. The attendances have been fairly good at all the activities, and certainly the pre-meet this afternoon was very well attended indeed and most helpful. So that is the list is the activities is as published in the agenda, and I commend it to you. Thank you very much.
Thank you, Michael. Has anybody got any questions about anything that's on the list, anything you don't understand, or any other questions about the activities? Amazing, quite a lot actually, and through the last 3 months. It's one of those busy periods, isn't it?
It's like number 9 buses, it all comes together.
Indeed. So yes, so thank you. Just say thank you to all the governors who did attend all these meetings, because they are very important meetings, and we do value them. So thank you for your industry around them. Okay, so we'll then move on then to the patient experience report. Chris Howarth, are you on?
I am here, and I've managed to unmute. So you do have the minutes of 2 meetings in front of you, but I'll just highlight a couple of things, if I may, Andy. So we've had 2 PEG meetings since the last Council of Governors, hence the 2 minutes. The committee's benefited from 2 very instructive virtual visits in September from the team looking at the realignment or the improvement of outpatient appointments. Work on this work stream is ongoing and has included both Shirley Holmes and myself, together with the team from the hospital. There's been some delays recently due to the pressures on the trust, but dates for future meetings have been provided this week. But in November, we were given a very interesting overview of the Healing Arts program, which assisted us in understanding the need for the initiative, its broad scope, and also provided an opportunity for us to ask questions and make observations. Both virtual visits were warmly received by the committee. One key focus of the PEG is receiving the quality report and asking questions of Andrea Lewis and Charlotte Broughton in order that we can understand more clearly the impact that NEDs are able to have in clinical quality assurance. We've been impressed with the degree of attention that's paid to this area, the work that the trust, the work of the trust on this, and the clear way in which Andrea and Charlotte explain those areas that give us any concern, and the degree of transparency with which these matters are dealt with. One new area of reporting this year has been the recording of compliments as well as complaints, and it's gratifying to see the level of compliments. This has been a very successful addition to our deliberations, and our thanks should be extended to Chris Marks, who was instrumental in calling for this. I commend the minutes which lie before you, and if you have any questions, Andy, I'm happy to take them.
Thank you, Chris. So any questions for Chris? I mean, I do think that the patient experience is such a vital committee, actually, and it's very helpful that you receive these at the moment virtual. Hopefully as soon as possible get back to face-to-face ones, but I think you've done a great job considering they've been virtual, so thank you. Lily.
I just wanted to say, first of all, it's really an extremely valuable and quite active group, as it should be. And it's great that there are quite a number of governors that are members of it. And I hope that some new governors will join as well. But in addition, I wanted to say that having attended the last board meeting, one of the really most enlightening sessions that I have heard from the patient experience was at the beginning of the meeting. And I thought that something that the patient experience group should really consider is to liaise with Tom and whoever has organized for this particular patient to come, because I'm sure that there would be others, because it would be very valuable to get the full picture. But this was a really expert patient talking not just about one specific interaction with the hospital, but a number of things going across the full range of services and not just in the trust here. So I think that would be really very useful.
Thanks. And perhaps Tom would like to be invited as one of the virtual visits, or indeed physical visits, next year.
I would also say that Lily is right, and Shirley and I had a discussion earlier as well. I would commend the last board meeting. If you don't hear anything else, hear the patient story from the last board meeting. It's on the website. I would really do that, because it's very moving, actually, and she's so impressive. She's so impressive what she was doing. Tom.
Yeah, just to respond, very happy to make the connection between Beth and the patient panel. I think that'd be important. So very happy to do that for you, Chris. And we need to make sure that we are linking Beth in, and indeed others from the patient panel and the wider group of patients who've got similar experiences to offer into the more detailed work as we go forward with the refresh of the strategy, which we'll be talking about later on, and then the implementation of the plan that emanates from that. But very happy to make that connection for the panel as suggested.
And indeed, perhaps we should add, Andy, this is usually your line, but I understand that the patient story is something that you start every board meeting with. You have been encouraging us to attend virtually board meetings. Perhaps we should say people should at least, especially PEG members, might at least look at the patient story at the beginning of each board meeting.
Yes, we tend to alternate between patient story and staff story, but both are equally valuable, of course, from a governor point of view, but particularly for PEG, the patient story. Yes. Okay, so thank you for those. Any other points on those minutes before we move on, I think, to the annual report in terms of reference, Chris? No, I think you're free to go on.
I don't see any. Well, the annual report just sets out, I suppose, in some ways, a bit of a repetition of what I've just said. So I leave that laying before people. I wasn't forced to go out of the room, but the committee seemed to feel that I could carry on. I think attendance has been good, Andy. When you look at the stats on there, and the terms of reference, we did have a little bit of discussion about whether there should be a tweak or not, but I think we left them as they were. Is there anything you wanted to ask, or any other governor wants to ask?
No, I think it was very clear. Anybody else want to ask anything on either the terms of reference or the annual report? No.
Okay, I can go silent for the rest of the meeting then, I guess. I'm sure I'll have some questions later.
I'm sure you will. I'm sure you will. Thank you, Chris. In which case we'll move on to item 5.4, which is the membership and community engagement group report, and that's Lily.
Hi, is there somebody who is trying to ask a question? Oh no, that's gone. Yes, I'm reporting in lieu of the past chair of the Meg, who was Danny Sparks, and who has really been ably spearheading this group for quite a long time. For obvious reasons, we haven't been as active as we would have liked, and also somehow our membership has equally of the group itself dwindled, not just because of the elections, but in general in terms of number of members. So the first thing that I would like to ask is that we need more members for the membership group. We need one of the staff members, please, and we need also at least 3 more of the governors, public governors. So with that in mind, just a quick summary. We had a very good presentation from the Deputy Head of Communications, and I'm sure you have had a look at all the various projects that she has talked about, including how has the healing arts developed across, not just within the hospital, but outside hospital, and the relationships that we have been building. Equally looking into strategy refresh and engaging more members into doing that. And I would just reflect it on speaking to some of the either new members or the current ones. There is still a question of what does the membership really mean? And we need to make that kind of message clearer when the new Aspire comes out at the beginning of the next year. So people get a sense, what is the benefit of membership of St. Peter's, and how do we get actively engaged? So as I say, we had a difficulty, obviously, that very successful presentations that the medical staff has been making open to members that were always very well attended, for obvious reasons couldn't happen. And I don't know whether we can start to, given what is going on and foreseeable future, whether we can start to think of some other ways of engaging members and having the interactions. But I would leave it at that and say thank you to everybody, and especially to Danny and Chris, who have been extremely active members of the membership group, and to encourage as many new members to join. David.
Thank you, Lily. David?
Yeah, I mean, I think it's a really good point, Lily. And I just wondered, I mean, one of the things we found successful is team talk. And actually this meeting means that the attendance is really good. So it doesn't mean that we can't do clinical presentations with that type of format. And that might actually suit members more. So I think that's what we should go back with the teams and just see if they can start doing that. And we have a virtual event like this, because I think we'd probably get even more attendance than we would normally.
Yeah, I think you're right. I think Anu, perhaps you could have a think about that with Lily as well. And Tom, I'm sure we can build on some of the strategy refresh events to. We've got people on there that aren't members, then we should be encouraging them, shouldn't we? And maybe all those people who have helped us during the pandemic, who may not be members either. And because I note with some sadness, that the overall decline in the number of members and the reason for it. So that we need to be active and going up the other way, really. But Lily is right. We have to articulate, what's the elevator pitch for being a member. It's not going to be sort of like Tesco's privileged access to hospital services, clearly, but there has to be, and really, I think the members do like clinical presentations. You know, when we used to do them face to face, they were very popular, weren't they, in the lecture theatre? So yes, getting those online I think would be helpful, but we do have to keep in mind the pressure that's on the trust at the moment, and that's not going to ease much before the spring, given we've got Surrey Safe Care going in as well. Edwin.
Oh, hi. No, I had a really good chat with Andy Brown and colleagues from communications team today at the opening event. And I think, yeah, I mean, perhaps we can do more on the hospital radio and with colleagues from the communications team to raise the profile and talk about the benefits of being a member. So perhaps more can be done there.
Yes, yeah, no, I think you're right, Edwin, and glad you enjoyed today's event. I thought it was tremendous today.
Really good, yeah.
Suzanne?
Yeah, no, and thanks, Andy, and thank you for the detailed brief, Lily. I mean, it is a really good, and we've struggled with this, haven't we? How do we describe the opportunity this presents? And I think, you know, more comms, internal, and as you suggest, across the radio, because obviously that patients listen to that. I suppose the thing is, it gives access and to insight and information that's sort of possibly a bit unique. I mean, people love something special, don't they? And then the other thing is, it gives them some influence and control. It gives them the opportunity to help us shape services for the future, or to bring our expertise to bear in their own community, where they might want us to provide support and advice and, you know, use our capabilities. So I think it's got to be as much about the opportunity for influence it gives those members of our constituency, as well as us giving them something, if you see what I mean. And that's helpful to addressing the issues that are facing communities, particularly as maybe linking it to the pandemic recovery might be another lever to pull. And then maybe some targeted communications. I mean, certainly Danny and I had sort of had a conversation about using either local media, social media, you know, because we need a younger demographic around this table, don't we? And more of a diverse demographic. So that might be, I'm sure Becky and her colleagues could help advise with, they'll know better than I am, but that might be the pitch.
Mm-hmm. I mean,
some part of the pitch.
Yeah, and I just wanted to add, I mean, I used to be a membership manager at East London NHS Trust, and we used to go to schools as well to recruit members in secondary school and colleges. I don't know whether we could do some virtual kind of presentations.
I mean, that would be brilliant if we could get some youngsters involved.
That's really good. Given our link with the academies,
exactly.
That would be, that's a great idea, Edwin.
Yeah, we could maybe ask them to help us, Tom, with that. The two, I mean, I know you've met with another academy now as well, so there might be, a bunch of opportunities.
Mm-hmm. Would you take an action on that, Tom, just to explore that?
Yes, very happy to, and I'm listening and cogitating a bit. I think there's a lot in this that we need to work through, and a lot relates, I guess, to our, sorry, I think I've frozen.
No, you haven't. No, you're
a lot
fine.
to on my screen. I had a lot to what we're hearing from the strategy refresh. And of course, membership were very active in that and engaged very helpfully and enthusiastically in it. So I think there's something we can take from that. And I think Suzanne's suggestions around kind of establishing groups with common interest, whether that's around the place, a locality, a particular disease group maybe, or stuff that's relevant to age, I think is a way to get into this. So, and I think a board and in Strategic Change Committee last week, we were talking about really upping our stakeholder engagement. Members are a key stakeholder group, as well as being part of our democratic, I guess, link with our communities. So we need to make sure that we've got a strategy that relates to how we engage effectively with them. So I'm really pleased we're having this conversation and happy to be part of it, but definitely we'll make that connection in with the school academies.
Great, thank you. Lily?
Yes, just to say, I think we have a great opportunity to link this with our strategy of being a community hub, because there are a number of different outreach areas that we have got with the services already, and that could become a way of doing something. So I'll take on to liaise with Tom, and also if Edwin wouldn't mind joining the group, that would be most helpful, because he obviously has the relevant experience.
Okay,
So
yeah, well,
thanks everybody.
will do. Thank you.
Sounds like you've volunteered for a group there, Edwin. Well done.
Oops.
Michael.
Just a very brief comment about the benefits of promoting membership as a demonstration of support. There was a huge enthusiasm for the clap for the NHS, perhaps something publicity on the theme of don't just clap, join.
Yes, indeed. Yeah, no. As well as clap, join, maybe.
Yes.
No, good point. Right, I think we need to move on. We're a little bit behind, but that was a good conversation, actually, and a very relevant one about, because it links so much with our anchor strategy and strategy refresh, etc. So that was very good. Okay, so I'm now going to hand it over to Suzanne, and you're going to talk through the highlights of the assurance report. Thanks.
Thank you, Andy. So this will be a bit of a rerun for the one or two governors who did make it to the board meeting. This is essentially the same board report, although there's been some adjustments made. It's in three parts. The first part is a summative assessment of the risks facing the delivery of the Trust's vision and strategy. The second part is more of a broad update and a bit of sort of pointing out key areas of development or particular challenges. And then the final piece is a detail around the financial position, which I'll invite Simon to provide you the detail on. So the detail of the summative of risk is really that many of the factors that we've been describing as presenting a really significant challenge to the delivery of the Trust's vision and strategy remain. And that really the key issue around our ability to mitigate those impacts is the team resilience. And it's really the team resilience that is continuing to bear the brunt of that risk and mitigating the impacts essentially to the patients almost invariably, although not entirely exclusively. So you can see the detail in the report if you go to the summative section at the back around each of the objectives. So just to give you a flavour, in terms of quality and performance, we continue to see numbers of COVID positive patients admitted to the organisation, somewhere in the region of around 30 patients. That number's been pretty static. It varies a bit up and down, but we have seen a diminution of requirement to be cared for in intensive care, and that'll be the impact of the vaccine. We have also seen, and it's been clearly demonstrated now, that the vaccine wanes over time, and so it's really important that we have been supportive and mobilising the third dose programme through our vaccination hub, and we've ensured that all of our team have had the opportunity to take that dose where they're within the criteria for having it. And particularly as the emergence of the Omicron variant is now clearly clearly establishing itself in our communities, even more important that so please do your bit to encourage those in your families and those that you have contact with, if they haven't taken up that offer. If they are over 40 now is the group being invited to. It is really important. So we don't quite know what's going to happen. David probably will want to comment at the end, but you know, it's not outside the realms of possibility that we're going to see a further wave as we head into Christmas and the New Year, which is just what we don't want to see. So, you know, my advice, both inside the hospital but also to yourselves, is that the the precautions that we've all been taking for nearly 2 years now remain as important as ever. And as we head into the festive season, we have issued our team with advice around, continuing to pay particular attention to things like lateral flow testing, hand space and ventilation, and minimizing social contact, and just being really considerate about one's approach to those things. We continue to see surging demand upon the emergency and non-elective pathways. That again has remained at above pre-pandemic levels for a number of months now. And continues to place a real level of demand across the organisation, and a lot of effort goes into maintaining a safe, high quality response to that. We also had, and you will have heard this, I'm sure, in November, an unannounced CQC inspection, which was just one more thing for our team to respond to. Have to say, I think in all my years here, it was the most impressive response from our team. I mean, these visits create a lot of anxiety in the organisation and a lot of additional work. And the team were really impressive in their commitment, professionalism and response to that additional challenge, but also how they led, certainly the divisional leadership teams involved, how they led their teams through this challenging scenario in addition to what they were already dealing with operationally. There's more detail in the report about the feedback from that, but you can see there that, one of the high level feedbacks from the CQC was that they could see that our team was committed to providing the best quality of care they could, and that all the patients they saw appeared well cared for. We wait now for the detailed report and ratings on us, and we suspect that will come in the new year. I've pointed to a couple of the two key mitigations of the concern we have for the well-being of the team as they manage these many complex and continuing demands. So the vaccine hub has gone great guns, and obviously the wellbeing hub, and some of you will have been at the official opening with Kirsty Gallagher and many VIPs and dignitaries this afternoon, and that was fantastic to see. I think the financial position Simon will pick up on. I suppose in the short term, the sort of the brief story is it looks a bit better in terms of we've got a non-recurrent means to balance the books by the end of this financial year, but that does not address the underlying financial run rate, and we do need to continue to work our way through that. Surrey Safe Care continues with great pace here at Ashford St Peter's. This is our transformational electronic patient record. We continue to be on track for our early March go live. We are doing lots of technical stuff behind the scenes, test trial loads and data ins and data exit. Simon's laughing. Data exit assessments around different specialties and pathways, and really technical stuff. But that is going largely very well. Of course, that is surfacing some challenges, as one would expect, but giving us the opportunity to fix them before we go live. The key thing now is really maintaining and accelerating team engagement and excitement around this project. We need everybody to be really on board with this. Getting their training booked and actually getting excited, and Simon and his team put together a fantastic kind of engagement event last Wednesday that ran until 3 o'clock in the morning to be sure that we could offer the opportunity to get a demo, meet some of the team, whether they were working nights or whatever they were doing. And really fabulous engagement and really reassuring as well. Talking to some of the nursing teams who were down there getting one of the demos, they were saying that they'd been quite anxious about this new system. They kind of wondered what it would mean for them, and obviously once they'd seen it, they came to understand that an awful lot of it is familiar. I mean, it's their work they're familiar with already, but it's enabled and supported in a different way, and it took some of the fear out of it for them, and I was really pleased to hear that. So really great stuff there. So I suppose, as the summary describes there, continues to be a range of sustained and significant risks affecting our strategic vision, but the pressure is unremitting. I mean, it is. I don't think any of us have ever known anything like it as we head into the. I think it's the third Christmas actually, with this in the background. And although we have seen some of the risks realising to patients through the quality of care, I don't think those are getting any worse. So I would say, it's about the same. It's no better, but it's not getting any worse. And of course, our focus has to continue to be supporting the team to respond to that. So I will just draw a breath there in case there are any particular questions around that aspect of the report. And if not, I will move on to the organisational update part 2.
Edwin?
Oh, hi. Thank you, Suzanne. So just referring back to the risk situation in terms of people, I noticed obviously that there was really good investment into the new wellbeing hub. So I can see that already people are enjoying it. And that vaccine booster program should also contribute to kind of making their job a bit easier. So really just wanted to congratulate that on that big investment into the hub. And inspection, obviously, we are looking forward to reading about the CQC findings, but I think I read one of your reports published immediately after the inspection, and there were some examples that I can't remember all the details, but some findings were basically less than basically something we wanted to avoid. In hindsight, it's easy, but looks like there were some things that were found that could have been perhaps easily rectified before the inspection. So I suppose it's all learning for future inspections.
So Edwin, I think there are two things to respond to that. Other execs might want to comment. I don't think there was anything there that I would say was easily avoided in advance of the inspection. So some of these things look uncomplicated on the surface. They're all complicated, and that isn't to say that I'm explaining it away. But I think that's a fact. Second thing to say is it was an unannounced inspection, so we didn't know they were coming. I mean, obviously we try and maintain the quality of care regardless, because that's important for our patients. But certainly we didn't have lots of time to kind of get our house in order before they turned up. That's not how they operate. And you're right, it's actually in the second part of the report, the detail around the CQC inspection and their high-level findings. I think the other thing I would just say before, and I can see David's got his hand up, so I will bring him in, but these are just their high-level findings. I think we really have to wait for the detail of their inspection report, which of course we will get for factual accuracy checking. So quite often the report arrives and we're able to say, no, that isn't right, or you haven't recalled that accurately, or no, that isn't what it was. We spent a lot of time submitting a great deal of data since they were actually here. And they've actually remarked that was one of the best data submissions they've ever seen in terms of completeness and data validity and so on. So, but you're right. So the things that are there that are of concern to us, there's some issues around the equipment in theatres. There is some issues around engagement, particularly with some of the senior clinicians. And there were some issues around the fabric of the building and so on, as well as some positives. So, but David, I know that David wanted to come in there. It'd be useful to hear from him, I think.
Yeah, thanks, Suzanne.
David.
Yeah, thanks, Suzanne. Thanks, Andy. I mean, I think you've covered it all, Suzanne. I mean, all I was going to say is that, it's good for the CQC to draw attention to these things. So we do welcome that. But also to put into context, I mean, the organisation and the staff have been through an unbelievable time where we have asked them to change, adapt, flex, move multiple times. And there will be some things that we possibly could have done better, but it is a different time. And what we need to do is wait for as Suzanne says, wait for the detail of the report, but also give them a bit more context on what we've been asking our staff to do, and they have been amazing, and they have had to adapt and change, and they're all a bit weary now, so we are seeing some of that.
Yeah, thank you, David. Good points. So I'm going to move on then, if nobody else anything else on part 1. So just to David's point, really moving us to point 4.2 talks to the piece that we've been sharing with you around recognising how fantastic the team have been. So there's some detail in the report there about how we've gone about commissioning and awarding the COVID Star, the yearbooks, absolutely fantastic set of events to launch that. We're not quite all the way there yet, so still a lot of stars to be awarded and books to be shared, but really, really fantastic feedback from the team, and I think a really beautiful thing to share with colleagues. The wellbeing hubs there, workforce systems. There's some interesting work going on at the moment to digitise our approach to rostering, and you might be hearing some feedback around that. It's been quite challenging mobilisation. Louise can give more detail around that, but I think we're getting there now actually. So challenging couple of weeks, but things are starting to improve now as it beds in, ever thus with new systems. But I think ultimately this will be a good move for us. Starts to integrate across the healthcare professions, gives the individuals more control, and ultimately will ensure our resource, if you like, our people resources deployed more effectively. Piece there around the new preoperative assessment unit, which the team are doing great work, and it's a new facility supporting our elective recovery and our centre at Ashford. So as okay, we've spoken about. I think the only other thing there, then moving on to people and the collaborations. So Pride in Surrey, second event back in September. It was really good to be there and support the team. And you can see, I think, the range of partnerships. So we're working on a diversification of our partnerships. So you can see Business South partnership there, partnership with Wentworth, all of which are about kind of creating a different community of partners and interested parties around our team and organisation in order to support us, and also in order for us to support the local community and be more present and visible as an anchor institution. So I'll leave it there and take any questions before I invite Simon to give the financial position update.
Thanks, Suzanne. Susan.
Come off mute, I think now. Just a question about the rollout of the Safer Care. Obviously, as a new governor, just wondering how that is planned, and having unfortunately painful experience of rollouts of other systems in previous lives, how risks from that could be mitigated.
Yeah, no, thank you, Susan. It's a really good question. I mean, I think I would say a sort of typical chief executive's response, really, very carefully and in very great detail is how it's being planned. But I'll invite Simon. You've got the right man here, because he's actually also the SRO for our programme, and he'd be able to give you a bit more detail and assurance. So Simon, can you answer that before we move on to the financial update?
Yeah, I'll try and do it. I mean, the reality is we've probably got 200 people on site today, all working behind the scenes on this. So there's a huge effort that's been mobilised to support all of this. Training is critical for us, though, so I'll highlight that. Our training starts on Monday. There's 4,500 people to train on the new system, so that's a key part of it. This week, a lot of those people I mentioned on site are doing user acceptance testing. So really thorough, walkthrough of the systems, testing everything's been built in the appropriate ways, etc. And that involves all of our clinical teams. So I think there's probably about 50 of those in Chertsey House at the moment, working their way through those patient pathways. The third one is the data migration. So particularly for health systems, there's a huge amount of patient data that needs to be transferred from one to the other. Things like future bookings of outpatients, of inpatients, people who are on lists waiting for one thing or another. So it's a multi-layer kind of strategy that supports that. The actual transition itself, because it's a single instance with Royal Surrey, over about the first week, there's kind of staged rollout. So that's the other thing to mention. And we do a dress rehearsal in January, so we do get it all right. So ultimately, the assurance comes from all of that.
You're right, though, it is a risky endeavour. And normally there's it's not a completely smooth. There are certain bumps that you go through in those weeks that follow when we go live on the 7th of March. So we're doing everything in our power to stop those bumps, minimise them, make sure it's smooth. I think inevitably it might be the odd thing or other that we've got to jump on pretty quickly. And again, we mitigate that with people at people's elbows, supporting the teams going through that, making sure we've got the Cerner support and others if we do lose some data or have to reinstate it or recover it or whatever we've got to do at that point. So yeah, a lot of effort, and yeah, we're in a strong place really at the moment.
Thank you, Simon.
Thank you, Simon.
Chris, Kathleen.
I just thought I'd add that the Joint Digital Committee has scrutinised this and does so on a monthly basis. And lately, it's probably worth saying we've also had this independently audited, Simon and Andy, by the NHS Digital, and also by an independent individual, an expert. So I think it's check and double check, and I think the JDC are assured about that. And I think we have to be very positive that there are hurdles, and then when you go through things like integration testing, you go through things like the multiple testing that individuals are from user point of view are scrutinizing it, then it is being looked at in considerable detail every step, and we would not go live unless we felt that it was safe to do so, and that applies for both hospitals. So I just wanted to add those points.
Thank you, Chris. And just to add that I sit on that Joint Digital Committee that Chris chairs jointly with Royal Surrey Ned, and it's safe to say that we're trying to take the maximum pain now to make it as easy as possible in March, but all my experience screams at me and say it's going to be difficult now, and it'll be difficult in March, and we just have to carry on with that, and so long as it's safe, of course. So, Edwin.
Just quickly, I mean, I read some papers around cyber attack risk and all that, so I'm guessing those 200 people who are working on this, some of them are experts in preventing cyber attacks.
Yeah, sure. That's we don't say too much about cyber, just simply because we don't want to publicise the risks around that for obvious reasons. But please be assured, we're working with kind of individuals locally who are experts in this, but also with the national teams and support and all those other arrangements that go in. And I think Cerner is a more secure environment in general than our historic kind of old or older PAS system. So we are constantly vigilant, but gaining assurance in those areas. I think it's probably a fair summary.
Yeah. Chris. You're muted, Chris.
Sorry, I just wanted to add, Edwin, that this is scrutinised by the Integrated Digital Committee, and at the next councillor quarterly update, I'll focus in on cybersecurity, and Laura and I will put together a presentation so you're brought up to speed with the sort of things we're doing. But obviously, this is a very sensitive area, and we do keep it close to our chest and in closed forum, because obviously we don't want people to know what's really happening. But we will give you a view so you understand the sort of quite considerable measures both ourselves and the IDC are going through, and the centre.
Thank you.
Thanks, Chris. So Simon, would you like to carry on with the financial update?
Yeah, sure. I think section 5 is probably where we're at. That details largely the first half of the year. In a sense, that's the easy bit because it's closed and certain and everything now. So we did meet our financial targets for that first half of the year and the surplus that was expected of us. We're a bit out of sync though in Suzanne's front bit, which was probably in the twos bit. I think that's actually got the month 7, so first month of half 2 data in there. That's the more challenging kind of part of this year for us. As Suzanne alluded to, we've managed to find a way of mitigating the sort of growing expenditure around the emergency side of things, but it involves us doing a lot of work on the elective and planned care side and making sure we recover the expected funds for that. It's a little bit uncertain at the moment in terms of our valuations, because that system has moved on to a new, well, not necessarily a new way of counting things, but a different way of counting things. So it looks at the impact on waiting lists, essentially, and we're paid for that around clock stops. So that's a NHS term for when a patient's treatment begins and the point at which they come off that formal waiting list or initial waiting list, I guess. There's also a dependency with the rest of the system. So it's not just our own performance here, but the rest of the system also has to hit their sort of targets. So there's a kind of interrelationship on the finances going forward with the system, just to highlight. Having said that, though, month 7, we were broadly on track for what we expected to be. We'll get more confident as we go through months 8 and 9, I guess. Certainly from the data I've seen so far on month 8, that's still supporting the forecast we're doing. But obviously, you know, the elective work is to a degree dependent on how much emergency work there is, the pressures, the COVID, other kind of issues as well. So I think it's a kind of watch this space, but certainly to date, we're hitting the trajectories and the financial performance we'd expect. But there's a lot of risk in the future, particularly when we go into next year, and if funding starts to be withdrawn at that point, yeah, if we do get into that environment. So I think the risks are for the future, really, as opposed to the present at the moment.
Thank you, Simon. Any
Thanks,
questions
Simon.
for Simon? No?
Okay.
Suzanne, you're back on?
I'm done, aren't
More or
I?
less done, aren't you?
I'm done, unless anybody else had any questions about the detail. Got the BAF overview here. We have a number of the non-executive chairs of the subcommittees, so between us, I'm sure we could handle any questions, or we can move to James for the performance report.
Just checking that there are no questions on that. Okay, so let's move on. James and I had a discussion earlier because I'm aware that the governor's raised a query about the appointment centre and various appointments and wanted that addressed. So I've suggested that James, at the moment, takes the performance, for the interest of time, takes the performance report as read and focuses on the appointment centre. And I know James has got some slides. They weren't in the pack. Apologies for that, but I think James would like to just talk through that, and they just illuminate the appendix there that is in your pack. James.
Thanks, Chair. Does anyone have any questions on the performance pack, or shall I go into the appointments? Because I've got to, my slides illuminate the appendix in the paper. Now I can take questions on anything. I'll do it that way. So I know there was a lot of discussion in governors' meetings, pre-meets as well, about the appointment centre. So I've got a few slides that I'm just going to share. It's only 4, but just to highlight where we are and the work that's happening at the moment. Has that come across? You can see them? Yeah, perfect.
That's fine, James.
Yeah.
It was fine.
Yeah.
Gone.
Now, what can you see now?
Nothing. Well, just your smiling face amongst many others.
That's good enough.
Okay.
Yep, we're back. Yeah. So you can see my slides now. Perfect. Okay, so just as way of context, the challenge that I have across the organisation, and then we manage through the organisation, is highlighted in this table. So we book for about 40 specialties in the trust, and there are various ways of doing that. So the appointment centre, which is we've got here, circle at the top, they book for about 30 of our specialties in the organisation, but there are, and that's new appointments, but there are departments across the organisation that book. So you can see them all around the outside, and these areas book their own. So all of these circles here are booked within departments, are booked outside of the main appointment centre, and some of them are really quite sizable. So the appointment centre books about 500 appointments a week. The ophthalmology department books about 1,000. Including follow-ups. The physios see about 700 a month. So there's just to give you a size of, there's a lot. So when we're coordinating the outpatient booking, just to give you a scale of challenge, it's not one department in the organisation. There's about a dozen. And then when it comes on to follow-up appointments, that's booked by every administrative office in the hospital. So just to give you a scale of the challenge of what we're coordinating. I think my slide might have dropped off again. Is that right? Yeah.
Yeah.
So on this slide, we're just going on to some of the initiatives that we're working on, some of the pieces of improvement work that are happening. So we're doing a big piece of work on appointment letters at the moment. Now, appointment letters is something that's come out through some of the governor discussions. It's also come out in our PALS response, our PALS inquiries that we log, and we make actions on all of them. So what's happened on appointment letters is they've changed quite a lot over time. People have added more and more sheets to be helpful, and it's become unwieldy. So we've gone back, and as Chris said earlier, the patient experience group have been involved in looking at some of the letters with us. So we've produced new template letters. We had a working group that's been in place since September, actually. It's got some patients and some staff on it. It's got a cross-section of people. So we've had outpatient receptionists, outpatient nurses, we've had somebody from our front reception desk. So these people know what our patients are arriving at the hospital, what questions they've got when they arrive, if they come to the wrong site, what information do they need when they get here. So all of that has been taken on board, and this has been circulated. These drafts have been circulated around the organisation, including to the patient experience group. And what we're trying to do is just make it simpler. We've taken lots of text out, and it's been made really clear. Also, what we've done on here is we've changed the leaflets. So over the years, people have thought it's been helpful to add more and more things. So when we send out a single appointment letter that says you've got an appointment for Monday, it actually has 6 attachments, 6 other sheets of paper put in every single one of those across the organisation. Bearing in mind, we do 500,000 a year. There's one about what to do with COVID. There's one about car parking charges. There's one about, do you want to be a governor? There's an application form for being a governor. There's a patient leaflet. There's 6 things that we put in this envelope in addition to the letter, and that has become quite confusing. So we've slimmed that down. The letter is clearer. We've put down one patient leaflet, which encompasses all the information we need about parking, COVID, visiting times, all that sort of stuff's in there. So that makes it a lot simpler. So that's a good piece of work on the letters, which we know has been a bugbear. The other thing is, we know that there are instances when the wrong letters have come out. So there's a piece of work internally making the letters easier to reference, and we're trying to take out a lot of letters. So when people book, there's a whole list of things that they can book from their letter. They need to choose the right one for their department. It's very easy when you're very busy to click on the wrong one, and that's why we want to make the list smaller so that there's far less chance of picking the wrong letter. So that piece of work is in train as well. So there's 2 things around the letters: making them clearer, slimlining the stuff we send out with them, and our internal processes around what letters we have on the system and getting rid of the old ones. Can you still see me? Perfect. So within the appointment centre, now this is kind of the mothership when it comes to our appointments. And when we get it right there, then we resonate that through the rest of those circles I was showing you on the graph on the table earlier. So we've got a few things happening in terms of communication. Earlier on in the year, you'll remember in the early summer, we had some problems with absenteeism, a vacancy rate in the appointment centre, and that created problems for us in terms of booking, speed of booking, and various things. So we're over that now. We have an increased number of staff back in the department, back online, and staff have been trained, so they were covering the phone lines in a different way. We were down to 2 people covering phone lines at any one point. Now every day there's 4 on any one of their 3 block shifts that they do on covering the phones during the day. They've also now got aspirations of how they can increase their opening times and how we can make sure that we're calling all patients, not sending out letters. That piece of work is in train. It's got a resource implication, but we are ringing patients as well, which is the thing that we need to move back to. We used to do it during COVID. It got a bit mixed, but although we are sending letters, we are getting really making a focus on now ringing patients and agreeing the appointment time with them, not just putting dates in the post. We've got some exciting work. We have a lady we're connected with from O2, the mobile phone and network organisation, and she's helping us with some work around, particularly at the moment, running an appointment centre. So she's given us some advice around what to do. Why are patients ringing us? What do they want to know? So we've taken the advice of what they do in O2, and we've done a survey for 3 weeks. And we've logged every single call and what every single call was for. And that's enabling us to revamp and improve our patient website, because now we know why people are ringing. We know all of the reasons. We can take that rich information and we can make sure that the website, which actually doesn't have a lot of information on it when it comes to appointments, is easy to access, easy to navigate, and has the information that people want to know. So we're working on that piece at the moment. That piece is ongoing. And it's great to have some thinking from outside, from thinking to industry, how people approach traffic, incoming traffic in call centres, and how they run call centres. So that piece works underway. Then we have our work on text messaging. Now, text messaging has become muddled during COVID. People have tried to help. They've tried to give more and more information. And we've got information on text messages going out that's a paragraph long. It's not where we need to be. We're going back to evidence-based management. We talk about evidence-based medicine, but we need evidence-based management. There's studies been done across 20,000 patients around what text messages elicit the most response and the most propensity to attend appointments and not DNA. That's just not turn up. So we're using that. We're using the text from those studies. It's a very simple piece of text. It just informs patients when their appointment is, what specialty it is, the date, the time, the implications of not doing that as a cost for the NHS, which it refers to, and then various options. You can text back and you can change your appointment, or you confirm or say you don't want it. We've also got, so that's a new thing because that had gone unwieldy. So we're refreshing it, it's crisp, and it's going back across all of our patient-facing clinics. Also, it's not differentiating between virtual and face-to-face, because that was a confusion that we know was coming back through our patient feedback. And lastly, on the improvements here on text messaging, we've now got this bespoke text messaging now. So when we're booking short notice appointments, such as eye casualty, where we need to book you in 48 hours, such as TWR, 2-week rule, which is our cancer pathways, there isn't time always to put letters in the post. But now what we're doing, rather than just agreeing the date with the patient, whilst the patient's on the phone, we can text them. So they have a text saying, this is the appointment we've just agreed with you. So it's actually in writing. So that's a bespoke, immediate thing. It's not a generic one. It's just for you. And it just represents a conversation we've just had. So that's another change, another thing that we've got going in on text messaging. And this is my last slide. There are a few other things that we're doing here, because this is by no means complete. This work needs to roll out across the organisation. So I showed you all of those places in the organisation where booking happens. Also, booking happens on the hospital's behalf in the community. And that's an issue that we're working through as well. So there's a lot of places. So here we've got a few other things. So we've got another survey, but we're going to go for a big survey so that we can really draw on what is the experience of people and what do they want to improve. And we're drawing on some expert patients we've identified, including the one that Chris referred to earlier in the meeting, the expert patient who was at board. So we're linking all of that piece of work together. The other theme that's coming through is around short notice clinic cancellation. So clinics being rescheduled or being cancelled altogether at short notice. Now, of course, we all know we're in a COVID pandemic. We all know that doctors are the same as anyone else. They have relatives, they have friends, family, children who come home with COVID and they have to isolate. There's all sorts of things that are driving our cancellation rate at the moment. However, we know that we need to do better. We've revamped our grip around consultant leave and absence and medical staff leave. We've controlled our processes for informing the appointment centre and informing our clinic scheduling teams. We've revamped that, and that will make a difference to the short notice cancellations that we're seeing. And the last piece we're doing on improvement on this slide is around virtual clinics. In some areas, virtual clinics are absolutely what patients want. We're getting hugely positive feedback. In other areas, we can see that it's driving up our diagnostic use. So because patients are not seen face to face, we can see that we are increasing diagnostic activity in some areas. We can also see that we're driving up numbers of appointments. So we're doing a really focused piece of work now on, or about to, we're planning how we need to take this. But our aspiration is to do this piece of work, to really work out what specialties it works well for, and in the future to be able to give patients a choice. So it might be that if I'm coming for a broken arm, I haven't got a lot of choices face to face. It might be that there are some specialties where I could have a face to face or virtual, because I do need to be seen, but I don't necessarily need to be there in person. And there are some specialties where actually I can do a phone, virtual or face to face, it doesn't matter. So that's what we're looking for. That's where the future is, and that's what we want, where we're going to take the virtual piece. And then the last piece is just how we run this out across the hospital. As I've explained, the appointment centre book the bulk of our appointments, but by no means all of them. We book on the community on our behalf. A lot of departments book new appointments, and then all organisation book follow-up. So we're rolling out all of this practice now as we're beginning to get around letters, the letters is being rolled out. The appointment text that I've described will go to every user. So we've got to roll this out across the hospital. So I'm happy to take questions on that, but that's the end of my few slides. But I thought it just highlighted a little bit clearer and in a little bit more detail the piece that we had in the performance paper, the appendix we had there.
Thank you, James. If you stop sharing. So, and just to say, I mean, this is basically to say that, you know, we are aware that the appointments process was far from perfect. And this was to give you a sense of what the team are doing to kind of fix that process. And of course, Surrey Safe Care as well will help on this, won't it, James? But
that's right.
You know, so the aim wasn't to go into too much detail, though I think James gave us some really helpful detail there. But just to give you assurance, really, that that they're on the ball and that improvements are coming. So if you want to ask any questions of James, not just of that or anything on the performance report, we've probably got time for 2 or 3 questions. Francis.
I just wondered how easy it is for staff to be aware that there are some patients who wouldn't be able to hear on the phone, who would have to have text messages or would need an interpreter if they were having a virtual appointment.
Yeah, that's a really, really good point, actually. I've been discussing that actual point with the teams this morning. The thing for us is how do we communicate in a way that reaches our hard to reach groups? Should we be looking at other languages for certain parts of the community? So what we're doing, we're looking to talk to Healthwatch, and we're looking to do a piece around understanding our population in a lot more detail, so that we know there might be some areas of the population where actually, if particular postcodes, we might need to send other languages, and we're looking at that because we only send stuff in English. The GPs do tell us if a patient has particular needs. So if it's special needs, if somebody's deaf, blind, has those sort of requirements, that's how we find out, or unless they're an existing patient and we already know. Otherwise, the team have to deal with that situation and say arrive on it. So if they come across a patient that can't communicate on the phone, they will send a letter. They will, you know, that is part of what they do. But it is for the main, you know, much better to talk to patients, because then we can agree what works for them rather than just expecting them to be able to do what we tell them when it comes to appointment times. I hope that answers your question.
And just a bit about how virtual clinics could be set up with interpreters, sign language interpreters particularly.
Yeah, they can. I mean, the amazing thing, so if we get virtual clinics right, they are incredibly strong. Yeah. Now, we've learnt from when we put out in, we were trying to put virtual clinics in during a global pandemic. It is not ideal. It is not the time to worry about how. So we didn't, and we've reflected on that, and we think there is a lot of learning. The team have been over to Epsom and looked through the way that they've implemented Attend Anywhere, which is the software we have. The reason I'm telling you this is there are rooms. So what they've done, they have the existing outpatient receptionists meet you in a virtual room when you arrive. That's the person you see first. They check your microphone with you. They check you can hear. They check the cameras right. They then put you from that room into the next room with the doctor. So they do that themselves, and they navigate that process. And it makes it clearer. It means the patient is ready, that the audio is working, everything's fine. It also means that we can bring other people in. So the thing that we can do better is that should a patient want their daughter to be in on the conversation who lives in Cornwall, they don't have to drive up anymore. They can come in on that, and we can arrange that in a secure way. That can be arranged. And the same with interpreters, the same with sign language. They can be brought into that virtual clinic room.
Thank you.
Thank you, James. Any other questions for James on? I hope governors found that useful. Michael.
Thanks, Andy. I'd just like to ask you, James, about 6 months ago, I asked why a lot of the communications, the postal communications, appeared to come from Bristol, and the return address was Bristol.
Yeah.
It's taken 6 months to get an answer to that simple question. If it takes 6 months to get an answer to such a simple question, how long will it take to get an answer to the big question?
Okay, thank you, Michael. I mean, I don't know who that question was put to, but we do know the answer to that. It's quite simply that's where the Syntec offices are based, but and that's their postal return address. So I apologise. I don't know where that question went, but I apologise for the delay in response. We do know the answer to that one.
I think Michael
trying to be more responsive.
Yeah, I think Michael put the question in one of the NED governor meetings. I don't think it was 6 months ago, to be honest. I know time goes quickly, but it's answered in the appendix. So you've got
it's answered. Yes, it's answered in the papers for today's meeting,
which is what we said we would do.
Yes.
So it is answered. Francis, you've still got your hand up. Is that an old hand?
Do I need to cancel that?
Oh, yes.
Yeah, that's great. Thank you. Okay, we're going to move on now. Time marches on as always in these meetings, but thank you, James, for addressing that particular point, because I think it is really important. And I know the non-executives were all concerned around the appointments, because it's such a primary point of contact with our patients. And it colours the rest of the experience if it's not right. So I think we've got a long way to go, but the great thing is you've got a plan to deal with it. So we look forward to doing that. Thank you. Right, we're now going to move on. Anu, I think you're on next. We've covered some of this, of course, but we're going to talk about the membership of the Council of Governors.
Yes, thank you, Chairman. As our Chairman mentioned earlier, it just highlights the changes to the Council as a result of recent Council of Governor elections. And if I could just add the welcome to Francis Ansell, Sue Bell, Sylvia White, Emma Gilmore, Aidan Parsons, Mohammed Imam, and Andy Brown. And also thank our leaving governors, Danny Sparks, Chris Marks, Neil Adolphus, Julian Roos, Oscar Garcia Casas, and Tom Allen.
Thank you, Anu. I was wondering, what are we going to do about the vacancy? Because clearly we didn't get enough votes or something. Can you just explain that for the governors, please?
Yes, of course. Yes, we were unable to fill the role in the Rest of England constituency. I think the reason behind that is that we only have 165 members belonging to that constituency. And although repeated messages were sent, even a postcard posted out to those members, nobody came back with an interest to putting themselves forward. So I would suggest that when we meet in the next constitution group, we look at perhaps amalgamating that constituency with another. I can't really think of any other way forward because of the low number of members in that area.
Okay, thank you, Anu. I just Lily.
Just a very quick one. Given that my and our constituency covers areas that are sort of in between two trusts anyway, and two ICPs. I think that seems to be a reasonable place to put it, or potentially Kingston, because that's again another one of those that is on the boundaries.
It's a good suggestion, Lily. I think you're right. You've pinpointed the two areas that could take it: Richmond and Kingston, or your own. We'll take that away. We'll take that as an action to have a look at that. Thank you. Anything else for Anu on this particular one? Okay, thank you. We're going to move on now to the strategy point, and we're going to look at the clinical effectiveness and national audit review. I don't know if Andrea was having a problem getting on.
I'm here.
Are you here? Oh, right. Okay, good. Can you explain where's this report been so far? Where else?
It's been to the Quality of Care Committee, and it went to the September committee.
Okay, I know Jane can't be here today, but just to give, are there any members of the Quality Committee, the NED members, that want to say anything before Andrea leads us off on this?
No, I think it's all fine, Andy. Thank you.
All right.
Fran's there. Great. Hi, Fran.
Okay, Andrea.
Okay, brilliant. Thank you. Well, I'll take the obviously the paper as read. It's an annual report, and it's the CNARG. I mean, it's the Clinical Effectiveness and National Audit Review Group. That's what CNARG stands for. And the key thing around this is with this piece is that it gives assurance. The CNARG group, it gives assurance regarding clinical effectiveness and the audit agenda. So really giving out the forward plan for the organisation. And then it leads and supports and reviews and analyses the implementation of recommendations from any national audits, inquiries and programmes. So to ensure that ourselves as an organisation, we're taking those recommendations on board in order to improve our own patient care and outcomes. And I think it's fair to say, I mean, the report covers 2020 to 21. And obviously this is last year and the start of the pandemic, and it was quite clear the national direction around particularly the audits programme was to suspend all of that really, and it was about for organisations to suspend it, and obviously from a national perspective they suspended a lot as well, in order to reduce the burden on clinical teams, to ensure that they could have time released to be at the absolute coalface with treating patients and freeing up their time to do that. So it was obviously good, done in the best way possible in order to do that. But of course, what it has done is paused a lot of the audit programmes, which are very good in order to obviously inform us around our practice. Having said that, though, it was local discretion as to what you wanted to do to carry on with doing some audits, and we did continue with that. And there were some national audits that did take place, but not at the pace or at the scale that they would have done. That has now, so this report very much reflects that. I think it's an audit light in that respect, or clinical effectiveness light in that respect. I'm glad to say that going forward for 2021 and 2022, that whole audit programme has been reinvigorated. So the next annual report we're reporting differently against that. But just to give a synopsis is that we did submit data to 31 national audits over this time span. And we did review 37 national clinical audits by us, and we took some actions forward following those clinical reviews. And one of the examples is the falls, which gives some really good actions and recommendations out of that, which we have implemented. Lying and standing BP being one, taken on admission and then followed up thereafter. And then there was 27 local clinical audits undertaken by ourselves as well. So we did keep on it really with regards to that. And one of those examples is improving the antibiotic prescribing, which we've seen report through our quality report as well that goes to committee. Appendix 2 highlights really the forward plan. So you can see there what's proposed really for 2021 and 2022. And I said everything's been reinvigorated and started up again, as you would expect. So I think I'll leave it there, Andy, if that's okay. I'm happy to take any questions. I'm sure both myself and David will be happy to answer any questions on this, but in a nutshell, that sort of gives an outline really of the activity
Okay.
for that year.
So summary is this report has been through quality of care. The non-executives on that have had a look at it, and you've had the presentation on the papers. So anything you would like to ask, please, any of the governors? Marcy.
Sorry, I'm not a governor or have a governor question for Andrea. It's just a point to say that going forward, the process around clinical audits will also come to the Audit and Risk Committee, and the focus on the outcomes of the audits will go to the Quality Committee, so that we actually will make sure that for the amount of investment put into this program, we get the maximum benefit.
Yeah, thank you, Marcin. That's a good point on the Audit and Risk Committee. The reinvigorated Audit and Risk Committee, I should say.
Yes. Having been on that this morning, it's yeah, it was the first time I've attended the Audit and Risk Committee, and it was a good experience actually. And I think, you know, some great work that's taking place there, and also clearly, Marcin, with your direction, great improvements will feed into the Quality of Care Committee as well. So, but there's a lot going on with audits.
And you have no bruising. You did.
And I have no bruising. I survived.
You did. You all the executive did. I was very impressed. I've indeed written to the chief exec today to say that you did an outstanding job, and the internal auditors were very impressed. So thank you very much for all your time.
And it is good to know that you're now wearing boxing gloves too, Marcin, so it isn't quite so hard.
Brilliant.
Thank you, Marcy. I haven't got to your detail. I haven't got to the detail of your email yet, but I'm quite sure that it's the executives that have done the brilliant thing. But thank you for sharing your feedback with me.
Sorry, Lily.
Just a very quick one. Thank you to Andrea and somebody who attends and have been attending CNARC now for a number of years. I was the one who actually raised the issue and the need for the report, because one thing that I noticed was that there was, how shall I put it, a certain level of unhappiness of the members that what they would like to do and what they were doing in that committee doesn't seem to have had the ability to percolate sufficiently higher up, or to have the real impact that they wanted in terms of learning, particularly when it comes to all the other strategic initiatives and the great amount of learning that's going on in the organization. And they felt that their expertise and the effort that they put in is somehow not as much reflected. And similarly, the input that they try to get, then they don't get enough, because the priorities of people on clinical side are really directed elsewhere. And I'm really glad that you will be now reinvigorating that, because everybody needs to know what is the value of their work.
Yeah, absolutely. And it's a key component, Lily. You're absolutely right. So I do know that the CNARC, because we've had this pause because of COVID, that's been reinvigorated in itself, as well as the work. But so we're refreshing the terms of reference and how that feeds in, and that fits in with what Marcin's has stated as well, because a lot of good work goes on here actually. That you're right, absolutely illustrates the learning, and then the next step for that, Lily, is that what we implement is learnt basically, and it lands well. So this is a really important key component to that as a learning organisation.
Thank you, Andrea. Thank you, Lily, for that. If we've got no other questions, we'll move on. We're more or less smack on time, which is good. And Tom, I'm going to hand over to you for the strategy refresh. Thanks.
Thanks, Andy. I'm gonna so I haven't shared any slides with you yet, but you'll get these slides after the meeting. I'm going to share them with you now, if that's okay. I'm going to just let me bring them up. Can you see those? Yeah.
Yes.
Okay.
Yeah, we can see them.
Thanks, Andy. I can't see you or myself now, which I find very disconcerting. And so clearly I can't see I can't see hands going up, but happy to take questions through them or at the end. Now there's quite a lot of slides, so I'm going to whip through them quite quickly, some of them, so I apologise in advance for that. But we're putting together a slide pack for sharing with people who are joining us on Friday, people who've been part of this process already, who we're bringing back together virtually, so that we can kind of check with them our proposals and how they react, how they respond to the input that was provided in the various engagement sessions during the summer. And this is a bit of a reduced slide pack based on that, and it really covers the kind of the approach that we took, a summary of the findings and our proposals. So just really quickly, and some of this you've seen before, we held a number of consultation sessions, all of them pretty much on Teams. And we also supplemented that with an online survey, which went out very widely, as you can see there. The survey ran through to November. We would have liked to have run it a little bit further so that we can get more numbers, but we really needed to get on with completing the process. This slide really just gives a summary of all the consultation meetings that we had. You can see there's a significant number of those involving members, involving different staff groups, etc., and various stakeholders. And thanks to all of my colleagues who are involved in supporting me with those. And we touched 287 people directly through those sessions, which I think is a good number of people that we've engaged in this. And as I say, we're going back to those people to test our interpretation of their comments to us in our proposals. And as you can see there, we recorded everything, made sure that we captured everything that was said, and there's an awful lot of detail, as you can imagine, in the responses and in the conversations that we had during that time. And there were some really fantastic discussions that we had as well. The survey, as I say, ran June to November. We had 207 responses. I would have liked more responses. We put an awful lot of comms and engagement effort into that, including social media, comms directly directed at the general public. I had Andy supporting me by doing an interview on Radio Way, which was really helpful and helped to bump up the numbers towards the end. But I think with these things, you're doing very well if you get a really significant number of responses there. There was never our objective to get a kind of statistically representative survey here. That would have been impossible, but we did get an awful lot of very good comments through the survey, and I'm just going to spend a bit of time going through the kind of the responses that we got and the demographics there. So you can see the first slide here, a predominantly female, interestingly, demographic, and you can see the age profile there. We did obviously collect protected characteristic data through this as well, so that we could get a good sense of the communities that people were part of and whether that affected their comments. You can see the ethnicity breakdown on that slide, and you can see here the relationship that people had with the trust. So 40% staff members, and in many ways that's not surprising because we did a lot of pushing the survey internally through team talk and through internal engagement. But I think 60% of responses from members and non-members who were not members of staff, I think is a really good level of engagement externally, and I'm really quite pleased with that. It would have been good if the absolute numbers had been a bit higher. So what did people say through the survey in relation to the different parts of the strategy? And I mean, I think this is very interesting. So, and again, I'll whip through these quite quickly. There are slides that I've taken out which actually have some of the detailed comments in that people made in relation to things like the mission and the vision and the aims, and they of course will go into the machine to be processed as part of the strategy refresh processing and the development of the implementation plan. But the overall finding actually is there's really strong agreement with current elements of the strategy, really strong agreement with the current mission, really strong agreement with the current vision, and really strong agreement with the aims of the current strategy, both in relation to the patient, our aims for the patients, and indeed to our aims for staff. So, and then finally, in relation to the North Star objective, we asked a very specific question about the North Star objective, and apologies, you can't see the full text of the kind of options here, but basically we asked people whether or not we thought that the North Star objective was already suitably reflected in the strategy, even though we might not have used the term North Star objective, and for thoughts on how it could be reflected in it. It might have been a bit of an unfair question possibly to include in the survey, but we included it nevertheless. And what it shows is that there wasn't really any strong feeling out there about how we should go about reflecting the North Star objective in the strategy, but generally from the kind of the free text comments, people found it important. They were pleased to see it there, and clearly we need to build that into the strategy as we go forward. But we didn't get any we didn't get any direct answers to the question of how we should do that. So that's something we need to reflect on. Overall, as I have said, and as you would expect, there's no massive kind of loud shout of feedback coming back to us saying you must change your strategy, which I interpret in two ways. One is that our existing strategy is very robust, and I think when we've reflected on this before and going into the pandemic, which really stress tested our strategy, that is the conclusion that we've come up with. So that's good to see that reflected back to us in the survey, and in fact that came back to us through the engagement events as well, but also that there is an awful lot in the detail of the comments that we've had back in. So although we may not need to change the strategy overall, there's an awful lot that we can tune up and put into the detail of the strategy that reflects the current scenario. And there was a lot of feedback that we got back that showed that we needed to update things to reflect the current scenario and to tune up particular parts of it. And that's where I'll kind of go now. I'll just what I'm going to do on the next few slides is to kind of intersperse key messages that people have relayed to us through the strategy refresh engagement process with our proposals for the updates to the different strategic objective texts within the strategy document: quality of care, people, digital, modern healthcare, and collaborate. And to give you a sense as Council of Governors of how the strategy is going to develop before it does come back to you at the next meeting for sign-off, or the next but one meeting for sign-off. So a lot of good support and trust for us as an organisation. Many people said to us and relate to us very clearly their sincere thanks to us as an organisation for supporting them through COVID, but not just through COVID, actually, for being their local hospital. And many people clearly had worked for us or were working for us and had undergone services with us, or relatives had, and there was an awful lot of goodwill. So I think that's really reassuring to hear, and it's good to know that we have that support from our community. There were some detailed comments really about how the emphasis around different elements of care. So some of the emphasis around what patient experience means, and how that has to include things like access to services was a really important one. There was recognition that we need to make maybe a sort of step change in relation to the way that we deliver care, given the lessons of the pandemic. There was quite a strong stream of comments around carers and referencing carers in the strategy, and ensuring that we had the right transformation plan to back that up. So the first set of proposals that I'll just share with you relate to the quality of care objective, and you can see there that the current text of the kind of strapline below quality of care is there on the first bullet point, and we're proposing to change this subtly, but I think in important ways. You'll see there the words grow and develop, which is clearly a change from create. We believe we have developed a good culture of learning, but we need to continue to build on that. And in fact, the conversation just now about CNARG is part of that whole process about how we bring more focus into those approaches, so that we can really learn and embed new ways of working and improved ways of working. The culture and the mindset of continuous improvement is an ongoing journey that we believe we need to continue to really focus on, and that's come to us through this process, and clearly continuing on the focus of reducing harm and improving patient experience. So a real tune-up in relation to the embedding of a learning culture and embedding new behaviours and improved behaviours to support patient care and patient experience. We're going to be tuning up the support for carers within all of this, obviously incorporating the North Star objective, and then really importantly, building into the strategy, and I'll put this in quality of care, but I suspect it will come in to a number of the strategic objectives, the importance of arts in aiding healing, in the healing process, and also I think in supporting staff well-being as well. So the healing arts really needs to be peppered through the strategy. We heard an awful lot about communication. And it was really good to hear James's update earlier about the approach that we're taking now to improve communication with outpatients and indeed across all of our patients, and communication. And you can see some of the comments there, and I've included some of the comments because it gives a sense of the level of detail that the level of detailed feedback that we got, both through the survey and through the engagement sessions. And communication was a really important element of that. Communication with patients, but also how we present ourselves to our community, and what more can we do to communicate positively with the community in a way which enables us to achieve our clinical objectives of supporting people to take responsibility for their own care, and to lead and really engage in terms of their care journey. So we need to look at how we can do that more effectively. And related to communication, obviously there was clear messages coming out relating to digital and technology. A lot of really strong optimism around the benefits of the new EPR, Safe Care, and that whole process, and where that leads us in relation to the integration of clinical pathways, and again what it means for patients, and how patients can engage with the process, with the system, and use of the patient portal, and some other comments in relation to some of the challenges around use of technology, which again we've reflected a little bit in this meeting around virtual consultations, but also the security of data and the issues around digital exclusion have come through to us. So and then just to add to that, the issues around communication, we heard some quite strong messages around transport and around the accessibility of services, and then in addition, before I go on to the next sort of part of our proposals for this, really through all the conversations we had, there were issues that related to green issues, sustainability, net zero, decarbonisation, and some of them came through very overtly, and some of them came through in relation to access and how we provide services in a way which reduces the requirement for things like transport. So just to turn to some of our proposals coming out of those suggestions, there's a number here on digital objective, and what I should say is that all of the proposals that I'm sharing with you now have been discussed at the relevant board subcommittee that oversee these strategic objectives. So just to pick a few out here, I've already mentioned Safe Care and the role that it has in supporting and delivering clinically led transformation. We've heard from James around improving booking and scheduling processes, and obviously the patient portal, which will come on following the go live of Safe Care as a second phase of that, will be a really important part of that. getting the right balance between virtual and face-to-face appointments is important. Issues to do with comms generally, and some more elements in there about innovation. We've already started trialing some automation systems within our cancer services team, and we're looking to widen that out, including things like artificial intelligence and machine learning will become tools that we'll be able to really make use of, I think, in this next period. I'll move on from there to some of the proposals that we are making around updating the modern healthcare objective. And this, I mean, in some ways, this continues the theme of the current strategy and the get it right first time approach. The GIRFT approach is an important part of that. That was referenced in the first strategy, in the current strategy, and we've really built our engagement with GIRFT, and we're looking now to work in collaboration with other partners to change and improve clinical pathways along GIRFT principles in a way which supports reducing variation across a much wider population and really builds on our strengths. But it also includes making sure that we can promote conservative treatments, not intervene when intervention isn't necessarily the right thing, and again to promote the preventative approaches as we've really tried and tested with our integrated MSK model for the last 4 or 5 years. There's much in here to do with developing the estate, and clearly we know we've got work to do there around the urgent care facilities here at St Peter's, where I am, but also we've got some pretty urgent things to do around the maternity facilities that we have at the Abbey Wing. And a bit further down the list there, really maximising Ashford Hospital as an elective hub, not just for us, but also for the wider system. And we believe there's a significant capital investment that needs to be made in there to really enable that to work as a system-wide asset. We are developing a green plan, which we will be publishing in January, along with all of our other trusts and our wider system. And we really do have a very strong level of staff engagement in that whole initiative. I'm really keen to push that forward and in due course present that plan to you, the Council of Governors, as well. I'm trying to move on quite quickly so that we can have a bit of discussion. There was an awful lot of input relating to inclusivity and diversity, and again, although there's a couple of comments there, that will be featured really across the whole strategy, because those issues have really kind of come to the fore since the strategy was published, and I think with COVID and the pandemic, the issues of inequality and the way that inequality has affected particular groups, I think, has really become very apparent, and we need to make sure that we work very purposefully to address that. That is an important element of our revised people strategy, and in relation to this, we are proposing, again, subtle change to the strapline, which really talks about continuing to be a kind of great place to work, but also a safe place to work, and about continually listening, improving, including people, the inclusion agenda, empowering and valuing everyone to ensure that there is the sense of everybody having a place within our organisation, belonging to it. And this is a slide that was seen at People Committee, and I include it because it shows what we are proposing in the middle column there in relation to our priorities for the people strategy. But it also shows really well the level of detail around the work that we intend to do, and how that links into what we were told on the strategy refresh consultation, and how that fits into the overall people plan. So it's just a great illustration, I think, of the way in which our strategy links to a whole range of other things, and the detail that has to go into the implementation plan. And we are close to the end now, so some messages that we received around collaboration, and I guess a recognition of how important we are as a collaborating organisation, and really how important that whole approach that we take is, and that it's perceived as important as well, and people can start to see the impact of that out there in our local area. And again, part of that is around the enablement of people to manage their own conditions, and to get support from us to do that. And so the final strategic objective is our collaborate strategic objective, and our areas to really focus in from the refresh are to do with, I think, probably becoming more purposeful about our collaboration. We've always known that it's important, but we've had a few years of really going at it, trying it, testing it, and finding where it works. Collaboration is, of course, likely to become a kind of legal obligation for NHS bodies through the Health and Care Bill, which helps. And we're really keen to continue and develop our collaboration within the NHS family, but also with other partners locally through the North West Surrey Alliance. But we also want to develop our collaboration to new sectors, and we've talked a bit about education, the Bourne Academy, the Reach Academy, and other school groups that we've been talking to over the last few years. We think there's really positive and opportunistic collaborations we can do with industry around things like our green plan, and we're already joined up with Business South, and we're looking to find ways in which we can engage with the business community around us to support the delivery of our strategy. We have got significant opportunities, I think, to really leverage our position as an anchor institution, and the slide also includes how we work with local business, support local employment through things like our recruitment hub, and to build ladders into employment from education through the work that we're doing with the schools and with the colleges, and then ensuring that through our collaborative work in the North West Surrey Alliance, we are really got strong plans to tackle the wider determinants of health and well-being and health inequalities, as I've already mentioned. So I hope you're keeping up. This is the last slide. This just tells you where we go. We've been doing this strategy refresh now in earnest since June. It feels like we've been doing it for a long time, but we are getting to the closing stages of it. As I've already said, we've reviewed the findings through the committees throughout November and December. We are going back out to participants on Friday and on Monday to present to them our proposals in a similar way to as I've just presented to you. They'll have a little bit more detail. We're aiming to sign off the updated strategy chapters in January, and to get a revised strategy document to the Trust Board at the beginning of February, so that we can then come back to Council in March to get the final sign-off of the strategy at that point before we launch. That is the end of my presentation. Thank you.
Thanks. If you want to, yeah. So there's an awful lot of information there, and I think, minded on what governors have said in the past, I think we should open ourselves, Tom and Anu, to governors, once they've seen the slides, being able to ask questions, submit questions through Anu, because there's an awful lot of information there. So I'll take questions now, Deb.
Thank you very much, Tom. Thank you, Andy. Just from Working Borough Council perspective, we're putting together a short response to the summary, and was actually discussing it with Julie Fisher this afternoon as to what the best timing of this is. We note that you're very kindly coming to talk to us as a council, and also to our elected governors from Woking. Hopefully those listening have been invited on the 5th of January. We had thought to present this to you then or just thereafter, but would you like it earlier in terms of being able to incorporate it within your draft or not?
Well, I think if it's ready, send it to us earlier, because then we can work on incorporating it, and we can maybe kind of respond to it in our presentation to the to council on the 5th of January.
Oh, that would be perfect. Thank you, Tom.
That would be fine.
Yeah, really helpful. We'll do that. Thank you.
Thanks, Deb. Any other instant questions for Tom? As I say, don't feel pressured to ask them now. Do submit them.
Yeah, and apologies again for whizzing through that so quickly, but we're working at some pace actually to draw all this material up for the session. So it felt opportune to me to share some of it with you, because I think it's always good to, it's nice to hear about the process, but to actually hear about the input, I think is helpful as well. So I'm very happy to take comments or have conversations after the meeting when you've had a chance to peruse the slides.
Yes, and Lily, we will be circulating Tom's slides, yes. Andy?
Yeah, it's just a quick observation. There's obviously a lot of information there that you've shared, which is quite encouraging and obviously what people want to hear. But also we're talking about trying to increase the membership of the is putting those two bits together. You really get, hey, this is what we're doing. This is the benefits of actually joining. And if you can collect that link together, you'll have really powerful information.
Yeah, I completely agree, Andy. I think it's a great opportunity, I think, to work out how we develop the membership and work with the membership actually to help us deliver on the strategy. I think the place agenda is a really important one on this, and I think the patient empowerment angle is a really important one that we need to understand where the members fit with that. And I think that does then start to describe a bit more maybe what you get from being a member and how you can really contribute to this whole agenda. So I think there's a good tie in there.
Thank you, Andy, for that. Okay, if there are no other questions, then we will move on. Thank you, Tom. You did well to get all that in the time. Right, we're now at 10 to 6, and we're on any other business. I want to invite Anu just to say a few words on the lead governor election and what's going to happen there, please, Anu.
Yes, very briefly. We will be encouraging all the public governors to put their nominations in for the lead governor position. I'll be sending out a role description and the kind of time that you'll need to allocate for the role, which shouldn't be too cumbersome. I know our leaving lead governor did attend everything, but we're not expecting that of our next lead governor. It's really the most important meetings of the Council of Governors, the pre-meetings, the agenda setting meetings. And what we will be doing is encouraging people who nominate themselves to perhaps put a video together, just outlining why they would be suitable for the position, and then we'll put it out to vote to the rest of the council, and that's every single governor, be it public, staff, or appointed. Was there anything else, Andy, you wanted me to clarify?
No, I just think the two main points are only public governors can put themselves forward, but that all governors have a vote. I think those are the two main points, and we'll make sure, Anu, in her usual thoroughness, we'll make sure all that is explained as it comes out.
Thank you.
Thanks, Anu. Any other business from anybody? I have one other item. Okay. Now, clearly, today is the last Council of Governors for Suzanne. And I think we ought to, in my hat as Chairman of the Council of Governors, I'm sure you'd like me to register your thanks. I seem to be doing this quite a lot, Suzanne, at the moment, doing it earlier in the Christmas message. But our thanks to Suzanne for being an outstanding Chief Executive for 7 years and 4 years as Chief Nurse before that. So 11 years of service to the Trust, which I think those of you who've been around that long will have seen some sustained and tangible progress during that time. And I, for one, have thoroughly enjoyed the four and a quarter years or so that I've worked with Suzanne. And I just wanted, on all your behalfs, really to thank you, Suzanne, and wish you all the best for your sojourn in God's own country.
Thank you very much, Andy, for your very kind words. And I've enjoyed it enormously. Learned a lot, achieved a lot. feel very proud of everything we've done here together with all of you and all of the team. And happy times ahead.
Indeed. Chris Howarth.
Hopefully I'm off mute, am I?
You are.
Yep. I think I must have been here for almost all of Suzanne's time then. I've also been around for 11 years. And I know sometimes, Suzanne, as governors, we try to ask awkward questions about staff morale and things like that. But I just want to register or to add to Andy's thanks, because if I cast my mind back to staff morale and how the trust was seen, maybe even in the community, 11 years back to 2010, and I look at how it's seen today and how the staff are today, and the general sense of camaraderie that there is in the trust today, I think that stems very largely from you and from your leadership. And I think we owe you a massive debt of gratitude for that work. So thank you. And good luck with everything else.
Thank you, Chris. Thank you.
And Lily.
I wanted to echo Chris's words and also say that particularly after the last board meeting and the discussion that was there, one thing that was so very clear is how open the discussion was and how collaborative the work was. And that obviously reflects itself all throughout the organization and the way in which patients also relate to the hospital as well. And having lived in the area for over 30 years, I really can sense enormous difference in terms of what's happened, not just internally, but also externally. And the whole leadership and the influence that the hospital has had wider, not just within Surrey Heartlands, but wider as well. And much of that is really Suzanne's doing. So thank you so much from all of us.
Thank you, Lily.
Thank you, Lily. And Michael.
Just very briefly, Andy, if I may, to endorse what everyone has said, and having had experience of not just Suzanne as chief executive, but of her two predecessors, I think she's been an absolutely fantastic chief executive, and I do wish her well, albeit in God's own country. I didn't know she was going to Yorkshire.
Yeah. My wife would agree with you, Michael.
But Suzanne, you've been an absolute wonder to the hospital.
Well, thank you, Michael. Thank you. And thank you all for your support. You know, it isn't about me at all. It's about the collective and the willingness of colleagues to engage, come together around an important but shared vision, I guess. And that's what we've been able to do together, work together to deliver something really important. And I'm so, you know, a huge amount has been achieved, but with your support, can't do these things alone. So thank you for all of the support of the governors and the lead governors over the years, and these meetings. I think these meetings are different as well, and they're enjoyable, aren't they? And it's a really important part of our democracy and how the public holds us to account. So thank you for your participation and engagement. And I will, I'll be back. You're all part of my DNA now, so I'll be back.
And I will know that Suzanne's really assimilated when she can sing me the whole Welsh national anthem in Welsh.
It's a test. I've got to take a test before I can cross the threshold.
Exactly. Thank you for that. So our next meeting, apart from we're about to go into the closed board, the next meeting is Wednesday the 2nd of March between 4 and 6 p.m. So at this point I will close this meeting unless you are contributing to the agenda. The other non-executives can leave the meeting.